Hello, everyone, and welcome to the Mowat-Wilson Syndrome Foundation's 2020 virtual conference. While our plans for this year's conference were upended by the pandemic, we are thrilled to be able to bring many of the speakers together in this format. We are confident that the presentations given over the next weeks will be informative. We're also excited by the opportunity for so many from around the world to be able to participate. So far, we have 21 countries participating today. While the pandemic has had many negative effects on our foundation, there have also been some positives. We were unable to hold the Lobs of Love tennis tournament and our annual golf tournament this year, but we partnered with One World Strong to do a virtual marathon. This event will run through the end of October. So far, the response has been amazing. We hope that this can become an annual event. We're in the process of upgrading the patient registry and hope to relaunch within the next few weeks. We added a community advisory board to provide ideas and feedback on how we can best support our community. There are some exciting developments in research which you will hear about in the upcoming presentations. While we will begin planning for our next in-person conference in the coming months, we will also plan for some regional events next year if that's possible. Our first speaker this morning or this evening, wherever you are, is going to be Dr. Meredith Wilson. Meredith Wilson is a consultant medical geneticist based in the Department of Clinical Genetics at Children's Hospital Westmead, one of the two major pediatric hospitals in Sydney, New South Wales, Australia. After medical school in Adelaide, Meredith initially trained as a pediatrician in Sydney, then did further training in clinical genetics in Sydney and at the Murdoch Institute in Melbourne. She has been a consultant clinical geneticist since 1991 at the Children's Hospital at Westmead and also at the Westmead Adult Hospital nearby. Meredith was head of the Children's Hospital Department of Clinical Genetics from 1998 to 2008 and head of the Westmead Hospital Adult Genetics Service until 2014, and was appointed as a clinical associate professor in the University of Sydney in 2009. Meredith's work involves many areas of clinical genetics and includes consultations with families and patients of all ages in prenatal, neonatal, pediatric, and adult genetic areas. She has contributed to a number of scientific papers in regard to different genetic syndromes. Dr. David Mowat is an experienced clinician and researcher with a primary interest in the diagnosis of genetic causes of rare disease and syndromes, syndrome recognition, and translational medicine to improve clinical outcomes. He is an AI and genomic projects in different disease cohorts, including rare Mendelian disorders, intellectual disability, and adult pediatric neuromuscular disorders. He has contributed to the discovery of a number of novel disease-causing genes. He is the co-head of the Center of Clinical Genetics and co-director of the Tuberous Sclerosis Clinic and Research Collaboration at Sydney Children's Hospital. In the late 1990s, when both were working at the Westmead Children's Hospital, they together identified a group of children with very similar features, which they subsequently published in the Journal of Medical Genetics in 1998 as a new syndrome. That condition later became known as Mowat-Wilson syndrome, in acknowledgement of the fact that David and Meredith were the first to recognize and describe this important genetic syndrome. Let's all welcome Dr. Meredith Wilson.
So thank you, everybody. I'm going to now attempt to share my screen. Can you all see that? Oops.
Nice job. Yep.
Oh, well, fantastic. The technology has worked. Okay. So it's lovely to be able to talk to everybody today, even in this slightly strange way. I'm going to be talking about diagnosing Mowat-Wilson syndrome, both clinically and genetically. And I'm going to try and advance my slide, which I can't seem to do. Okay. I did somehow. So I'm presenting from Sydney in Australia, and it's not 7 a.m. here, it's 8 a.m. because we just had daylight saving change last week. And you can see beautiful Sydney, which does look like that today. And the two children's hospitals kind of at both ends of Sydney that David and I work at. And I just wanted to make a little note of the various conferences that David and I, or at least one of us, has talked at over the last few years. The last being the European conference at Cascais in Portugal. And Rui, I hope I almost said that correctly. So beautiful place. There's some lovely photos there, and you can see the benefit we get from going to these conferences where a number of us can talk to you and you can talk to each other. And it's really just wonderful. If you ever get the chance to attend something in person, I highly recommend it. So as Debbie said, Mowat-Wilson syndrome was first published as a clinically recognisable syndrome in 1998 in 6 children that David and I had come across or found through colleagues, and we recognised that they shared many characteristics, but in particular their facial characteristics plus or minus some other physical features. So there's 4 of our first 4 patients. And we're quite proud of this because this came from Australia, you know, where we're at the other end of the world, and most things don't tend to originate from here. And we said, and this still remains true, that all patients with Mowat-Wilson syndrome do share somewhat similar facial appearance. All patients have an intellectual disability, which is usually severe, but can be moderate and occasionally mild. And in almost all cases, they are the only affected child in their family. Most have eventually develop a microcephaly or a small head. Many have epilepsy. We thought early on that Hirschsprung disease would be very common because that's how our patients first came to attention, or most of them, but that's turned out to be much less prominent in the group overall now, and that frequently people had heart disease or agenesis of the corpus callosum, so a brain difference, hypospadias, which is a genital abnormality in males. So, and you all know, because you've all been diagnosed, the range of features that can happen for people with Mowat-Wilson syndrome, starting from the time of a baby to going through to adult life. So of our first few children, 5 children had normal chromosome tests. When I say chromosome test, then we meant this thing called karyotype, which is a picture of the chromosomes under a microscope. And it's a very useful test for showing big, big, big changes, as in deletions or missing chunks of DNA. But to see something on a karyotype, you actually have to have 5 million bases of DNA missing. So it's a very rough test. It's an extremely good test for what it does, but it doesn't do everything. But one of our patients did have a visible missing bit at the partway down one of the copies of chromosome 2. You can see the little red arrow, and we could see that under the microscope. So we thought that couldn't be coincidence, and there was probably something in that region that was the reason for people having Mowat-Wilson syndrome. So our other children had normal chromosomes, but this child gave the clue. But we made that the statement then, and it still holds true now, that facial appearance is really the key to diagnosis, once you recognise it. So a few years went by and there wasn't nothing really in the published literature. David and I used to get some emails about, could this be Mowat-Wilson syndrome, or could this be this condition? Until about 2001, when the actual gene was identified. And it did turn out to be that there was a gene in this region that was the cause of Mowat-Wilson syndrome, the only cause of Mowat-Wilson syndrome. So this diagram, so firstly, when the publications came out, they were talking about a gene called CYP1, because that's what it used to be called. Then it changed its name to ZFX HX1B, so now fortunately it's back down to ZEB2. So all of those 3 are the same gene, just different systems of naming them. And it turns out ZEB2 is right in the middle of this region that the deletion was in that patient of ours. And you can kind of see that pink bit is the region. We've got the chromosome lying down on its side now, and the little red stripe in the middle is the ZEB2 gene. And underneath that, I've expanded that region to give you, you don't need to look at all the names of things, but those red and green things are the genes that also live in that region or are located in that region. So you can see ZEB2 kind of in the middle, and some green and red things, which are other genes around the region. So if people just had a deletion of the ZEB2 gene, they get Mowat-Wilson syndrome. And in fact, if you go out sideways, all those green genes kind of don't really matter if you have a deletion of them. And some of the other red genes, they could possibly give you additional features if you had a deletion of those. But basically, most of the deletions we see just involve the Mowat-Wilson syndrome gene or a little bit further along. And we know that mutations in the gene inside ZEB2 or deletions that include ZEB2 can equally cause Mowat-Wilson syndrome. They cause the same kind of condition. So subsequently, I always get to do this history bit, by the way, but so don't worry, there'll be other things that you haven't heard of that you'll hear about later in the day. So the recognition was gradual around the world from 2001 to 2006. There was a lot of publications, and I'm not sure you can see the whole screen there, but from Jean Amiel in France, Professor Yamada in Japan, Christian Zweer in Germany, Italy, Livia Garavelli, who's been amazing since that time with her interest, and of course, Margaret Adam, who many of you know well from the USA. And at that point, 2006, there were about 100 individuals in published papers. But now there are at least 350 people in published papers, but of course, many, many, many more who've been diagnosed and are not in any paper. But many of those people belong to this support group. So despite all of that, the recognition and test confirmation of the diagnosis remained challenging for most people. So the facial features, and particularly occurring in conjunction with those other features, were very recognisable to some experts. And of course, they were very recognisable to David and I. We felt like we could be absolutely sure just by looking in nearly all people that we saw or was sent to us for an opinion. But many people can't recognise something if they've never seen it before. And I'm like that too. With many syndromes that I've never seen, I won't recognise that person when they walk into the room, even if it's reasonably well described. There are too many of them for everybody to be an expert in everything. And the congenital anomalies that some people with Mowat-Wilson syndrome have are a major clue, particularly if there's Hirschsprung disease. But all of these other features can happen in many syndromes. There are many, many syndromes that have intellectual disability, congenital heart disease, agenesis of the corpus callosum, for example. Intellectual disability and epilepsy are very common. They're the most common reason for coming to a genetics clinic, and they have thousands of different causes. So it can be difficult unless you're very familiar with the condition. And the other issue was that access to gene testing was very limited back then, and possibly still is a little. Even when Mowat-Wilson syndrome was considered a possible diagnosis, often people wanted proof, apart from me and David saying, well, yes, I think so. So I thought I would just quickly run through some things about genetic testing. I'm sorry, this is a little bit technical. David's going to go into things in a little more detail and perhaps try and make it a bit more understandable. But I think it is useful just to reflect on some of these things and how they've changed over the years. So we mentioned chromosome tests are the first thing that I wanted to talk about. So chromosome tests have changed as well now. So we have the old-fashioned chromosome test, which is called the karyotype, which those little wriggly things in that box up the top left. That's what you can see under a microscope. And we know that that will detect about 1% of people with Mowat-Wilson syndrome. They would be diagnosed because there'll be a deletion or some other difference seen on karyotype. Now, the newer kind of chromosome test is called chromosome microarray, or CMA for short. And I've got a picture of a piece of chromosome microarray up the top there. And the green line with the little blue dots on it is the important thing. So it's another completely different way of looking at chromosomes. And it's basically looking at the number of copies you have of little sections of the DNA. And they're little samples taken from all across all of the chromosomes, like little at intervals. There'll be a piece of DNA that's actually put on a little glass slide. That's the test slide. It's called the array. It's arranged there. And then your child's DNA is washed onto that slide and it sticks. So if your child has 2 copies of any particular point, it will come up along that line that's called 0 there. And you can see that green line in the middle. That's where it should sit if you've got 2 copies. But if 1 copy is missing, you'll only get the equivalent of 1 copy sticking. So you get the line drops. So you can clearly map or say from this point to this point, there is only 1 copy of the DNA. It actually works the other way around too. If there's more copies of DNA, you get an increase in the graph. But for the purposes of Mowat-Wilson syndrome, most of the time, it's a drop in the copy number there. So chromosome microarray, because it's so much more detailed than karyotype, is now the first line test for any child with developmental delay and congenital anomalies. So in most places anyway, that test will be done first before any other test is even thought of. And it has other names. Some people call it a CGH array or a SNP array, but they're both different types of chromosome microarray. They both count copies of sections of DNA. So much, much better than a karyotype at detecting those smaller deletions. You cannot see the ZEB2 gene in a karyotype. You cannot see if it's missing, but you can see if it's missing with a chromosome microarray. And the other good thing about array is you don't have to suspect the diagnosis before you do the array, because it looks at everything, all chromosomes. It will pick up deletions for whatever condition, if it's caused by a deletion that's big enough to be seen by the array. So the detail of the array actually depends a bit on the array that you choose, and there are all sorts of different ones, and some of them are very what we call dense. So the green line one that I've got up there, it's got, you can see all those little tiny blue dots. There's lots and lots and lots of places are being looked at. But above that, I've just artificially put in some blue dots, and that would be if you only looked at those 5 positions instead of those 300 positions. You can see there that that deletion that's been picked up by the green line array would not have been picked up by that other array, that didn't look closely enough. So that's just to give you an idea of how arrays can be different and how much they can pick up. So although it can detect deletions of ZEB2, the gene, and even probably pick up deletion of, say, half of ZEB2 or a quarter of ZEB2, probably not more than that, it doesn't detect mutations, that is spelling mistakes within the actual code of the gene. So arrays don't look at the spelling of the DNA. So if your child's MWS is not caused by a deletion, this test will be normal. But about 10 to 15% perhaps will be picked up on this test. So gene tests actually look at the spelling within a gene. So this might be difficult for the interpreters, but genetic tests are anything that tests our genetic material. So a chromosome test and an array are genetic tests. A gene test is also a genetic test, but it's a test of the inside of a gene. So that was possible, yes, since the gene was discovered in 2001. And a bit of technology here, the technique's called Sanger sequencing, and I've just shown some pictures of that down below. And I don't think I've got an arrow, but I'll try with my own arrow at home. If you go into those little things with all the little peaks on them, down in the middle of the slide there, you'll see some genetic sequence, CAT, etc., and some little peaks. If you go into the middle of the first picture there, what you'll see as you go along is you'll see just one peak at every point. The peaks vary in their size, but there's just one. But then in the middle, you see 2. And what that's saying is the Sanger sequencing is picking up that there are 2 different versions of the DNA there. One has the right spelling and one has the wrong spelling. So that says this child has a mutation or a difference on one chromosome at that particular point. So that's a sequence, single point sequence variant. And there's another example. And you can tell which part of the gene they're in, etc., etc. David will talk a little bit more about gene tests later. So sequencing picks up mutations or changes within the gene. Now, it doesn't pick up deletions of the gene. It picks up, so if the gene's missing, it can't see that sequence. It'll just go and sequence your other normal copy of the gene that's there. So it looks like everything's fine. But deletions need a different test at the moment anyway. So to have that test, you needed to think of the condition. You had to say, I want the ZEB2 gene sequenced. And then you had to find somebody who would do that for you. And for a long time, we had to do that through research people. We had to send the tests to our colleagues in France or sometimes in Germany, etc. We did a little bit in Sydney as well, but it was actually quite difficult to access the testing. You couldn't get it even if you wanted to pay for it. It had to be through one of the research groups. Gradually, that did change, but you still had to think of it, and that was the problem. Then And it's the same problem for other conditions as well in genetics, where if you don't know what you're looking for, you think, well, what am I going to do? Am I going to test 20 different genes separately and pay, $1,000 each time? No, I can't do that. So gradually gene test panels came into existence. Now what these are is that their multiple genes are looked at once. As a particular laboratory will say, well, I'll look at these 10 genes or these 20 genes or these 100 genes, and they kind of put some efficiencies into the system to allow them to do all that testing for perhaps not much more, maybe double what a single gene test would cost. So it's a bit of a saving. So if your condition happened to be on that panel, you ask for that test, you'd get your answer. And so the panels all varied, and it's actually been incredibly confusing for clinical genetics to work out which panel am I going to use, how much does it cost, who does it, etc., etc. It's still a challenge for us. So some of the panels included ZEB2. So if you were a person who didn't know what Mowat-Wilson syndrome was, and your child that you were looking at had intellectual disability and some other features, you'd say, well, I think I'll do an intellectual disability gene panel. It might have 500 genes in it, and if one of them is ZEB2, you'll get an answer from that test. And again, it was expensive. There were access issues. In Australia, our hospitals had to pay for the test because it's not covered by our public health system, or was not. Actually, still isn't. So then things changed again, as they keep doing in genetics. It's one of the fields that is very hard you have to keep running if you work in genetics. You have to keep running, and you have to keep thinking and changing what you do. So then these techniques called whole exome sequencing and whole genome sequencing have become more prominent in the last few years. And again, a bit of technology, but what they involve is we have about 20,000 different genes, although we only understand about 5,000 of them do. Only about 5,000 of them have so far been linked to a particular genetic condition. So of course ZEB2 is one of those genes. And the way this works, which you do not have to understand, is that your DNA is taken and fragmented into lots of tiny little sections. Not tiny, maybe 100 bits of genetic code long, and they're called reads. And it's actually quite easy to actually quickly read one of those short sections of DNA. So the technology, a completely different technology, is used to chop it all up, quickly read all of these little short segments of DNA. Then you've got a whole lot of little sorts of segments of DNA, millions of them. And then the computer has to then put them all back together again, match them all up. In kind of, you can see that layered picture there. Each one of those grey things is a read. And the computer has kind of sewn them up so that they kind of match back together. And then it looks and says, what did those reads show at every point along there? What did those reads show? So on the coloured bit, you can see the coloured little CAGT. That's the normal code, what it's supposed to show. So most of that picture there is showing the normal code. In the middle, you can see a place where there's some red T's. Now they're not normal. They should not be there. It should be a C there. So that's saying that so many of the reads, this is just part of a result. Many of the reads at that point have a T instead of a C. Maybe about half of them do. That means we have a mutation on one copy of this particular gene at that point. So this is a C to T mutation there. So that's actually, now we use a different language. We call these things variants. So we're not naming it in any other way except to say it's a variation from the usual at that point, because it's very complicated, but variants in a gene can be pathogenic, which means they cause a condition, what we used to call mutation, or they can be completely benign. And the whole challenge in genetics now is working out what's actually something that would cause a condition and what's actually benign. So while we have a very good idea about those two things, there's also a group in the middle, which we call variants of unknown significance. Every gene, every condition, every test we do has a potential that we're going to get that very unhelpful statement, we call it. So David might explain a little bit more sometimes we get a variant of unknown significance in this gene on this kind of testing. And in genetics, it's really important to know and to remember that the tests have not overtaken the need for clinical interpretation. So you need to have somebody who knows what they're doing to interpret a test. It's usually right if the lab says this is Mowat-Wilson syndrome. Sometimes it's not. And that's where we need our clinical geneticists and experts to come in. And again, of course, with all genetic tests, they're still expensive. The whole exome sequencing, the top one, it looks at a lot less DNA than the whole genome sequencing. I won't go into the details, it's not important. So it's now the preferred option in many genetic centres, including ours, if we were choosing to do this sort of test. And the cost to it, the access to it, the insurance depends on region by region, country by country. And our country, Australia, has now just put in what we call a Medicare item number for this test in young children who meet certain criteria of intellectual disability and congenital malformations. So for the first time in since this technique's become available, we can now choose to use this without sending our hospital broke. So that's great. It's very important for me to say that we, David and I, for example, and maybe many other people, would not use this technique if we saw a child with Mowat-Wilson syndrome, because we know we don't need to look at 20,000 genes to diagnose this. We can just do a single gene test still, and a single gene test, although expensive, in Australia it might cost $500. This test will cost, 3 to 4 to 5 times that. So, doctors can still choose which tests they do. But for many people, this will be the test that their doctor has chosen because they don't know what condition they're looking at, and that's very reasonable, and that's how they got their diagnosis of Mowat-Wilson syndrome. And I will just point out very briefly, I'm getting to the end of my talk, that this ability to test so widely has a lot of implications, not only for the diagnosis of Mowat-Wilson syndrome, but for the diagnosis of many syndromes. And there are new situations where we're using testing in different ways than perhaps we could before because the technology has changed. For example, in the newborn intensive care, there's been a lot of studies in the last few years looking at rapid turnaround testing of this type. So rapid turnaround might mean 3 days to 2 weeks. 3 to 5 days is one of the commoner times, to look at critically ill babies. So babies who are incredibly ill and may have multiple congenital malformations and look different. You don't know whether they have intellectual disability. And that information from that test might help to, if there's a diagnosis, which there is in perhaps 45 to 50% of babies who have this test, can be used to guide management and care discussions and understand what's actually going on. And a lot of us are involved in research, and I'm certainly involved in this kind of research as part of something we do call acute care genomics in Australia. And that's been going on for a couple of years with those kind of results. And also it's now extending into the prenatal testing situation. So rapid whole exome sequencing in babies who are still in the womb, who have ultrasound abnormalities that suggest that something might be going on. The chromosome test hasn't given you the answer. And that is now subject to a lot of research, and it's possible and is being done with that information being used to offer choice and guide management discussions for those who wish to have access to all the information possible. So of course there are many, many, many ethical issues with both of these approaches. Some of them are part of what medicine has always had, and some of them are new to this particular kind of testing. So briefly, in summary, chromosome karyotypes, maybe 1% show an answer. Most of your children will not have had a karyotype because it's outmoded. There's a few exceptions, but we won't go into that. Chromosome microarray test, maybe 15%. Gene sequencing, whatever way it's accessed, about 80% of the Mowat-Wilson children will have a mutation within the gene. And there are a few other unusual things that have come up. Rarely, the clinical diagnosis is certain. So David and I, for example, get sent somebody's picture and we say, no, they've got Mowat-Wilson syndrome. There's no doubt about it. And yet none of these tests have shown an abnormality affecting the gene. So the question often comes up in genetics, could there be another gene Well, we don't think so. We think that would be very, very, very unlikely. It's possible, but it's probably not the case. And it's more likely to be due to some rare variation, something that's disturbed the way that gene works that we can't currently get to by our current technology, but we probably will be able to in a few years. So then I'm going to move on very quickly to genetic counselling. I think most of you know that Mowat-Wilson syndrome is almost always due to a new mutation or deletion affecting one copy of the gene. That is, it's not carried by a parent. And the way it happens, it arises during the making of that one egg or that one sperm, because we actually have to copy all of our DNA to make an egg or a sperm. And we always make little typos or differences in the DNA, thousands of them, in fact, and most of them don't matter at all, but occasionally they fall in just a place where it will matter. So it's not something wrong with a parent that this happens to. They're not faulty. They're not different from any other human being. It just is a random thing, and it's just where they fall that determines whether there's a problem or not. So because it's a new copying change, recurrence in siblings, so having another affected baby, a brother or sister, is not common, but it does occur sometimes. So maybe 1 or 2% of families could have a second child with the same condition. So why does that happen? That happens by this, we call it gonadal mosaicism. So mosaicism means two different things. So cells, one cell being one way and another cell having a different type of genetics in it. So one with a normal Z2 gene, one that has one gene that's not normal, so a mixture. So gonadal mosaicism means that the rest of the body is fine, the cells in the rest of the body do not have the mutation, but in the gonads, and that's the testes in men and the ovaries in women, there is a bunch of cells that already have developed this mutation when they were being made, as we were being made, so way back. And because they're there, they can send off more than one copy of themselves. So they potentially could lead to somebody having several affected children. And the important thing about that is that because the mutation is not in the blood cells, you cannot tell who has gonadal mosaicism from the outside, and you cannot tell by doing a blood test in that person. But we can reassure people that the chance that anybody has gonadal mosaicism is low. But if people are concerned about the chance of it happening again, they can have a test in the subsequent pregnancy. If we know the mutation in their child, we can go in and specifically look for that in the next pregnancy for extra reassurance. Now I'm trying to go to my next slide and it's not going. Not sure why.
Try passing your mouse over the slide and using.
Click on it and
yeah.
Thank you. Another way. So the benefits of making the diagnosis we've talked about. Accurate diagnosis leads to access to information for doctors and families, understanding of what complications can occur, particularly say knowing that undiagnosed short segment Hirschsprung disease might be the explanation for severe constipation in some children. We understand the low chance of recurrence for those planning more children. Something that many people have said to me is this relief of guilt about why your child has a condition. All geneticists are very familiar with sitting in a room, usually with a mother, saying that she thinks it was her fault. It must be my fault because I bore this baby. Father's less likely to think it's their fault, and some feel relieved by knowing it's not something they could have done anything about. It's not something they did, it's not something they didn't do. It is a random event. And the best thing about making the diagnosis, perhaps, or one of the best things about making a diagnosis, is that you can then have access to a support group. And for this condition, there is such a fantastic support group. And that is, a wonderful advantage, both personally and actually for research and for those who want to move forward in doing something more than just diagnosis. So I want to end by thanking the Mowat-Wilson syndrome community worldwide, patients, families, colleagues, even my friend, Dr. David Mowat. And I'm so honoured to have met and learned so much from all of you over these years, and I hope to meet many more of you in person one day if we're allowed to travel and see each other. So thank you, and I will finish.